Hi, this is Patrick DeHeer, and I'm going to be discussing the Baumann Gastroc Recession system by DeHeer Orthopedics, and this is one of my surgical videos from a recent case. I like to draw out my skin incision. I tend to make the incision about 2 finger breadths below the tibia and at the widest part of the gastroc soleal complex in the kind of meaty part of the calf, about 4 centimeters in length and parallel to the tibia. I'm kind of showing the landmarks now. I like to use a 10 blade and I go through the skin and superficial fascia and ligate any vessels as needed. Then I'm going to use a Metzenbaum scissors to undermine the soft tissue. It's really important to try to limit the horizontal undermining of the skin edges, which damages the perforators to the skin and can lead to wound dehiscence. Trying to keep your undermining more vertically oriented will help reduce the injury to those perforators to the skin. Then I'll use my finger to get down to the deep fascia. And sometimes you can feel the saphenous nerve. It'll be on the deep fascia. If you feel it, you can just push it up. The great saphenous vein should be between the tibia and the incision, but if you see it, you can retract it. I like to use a Wheatlander or a Chung retractor to open up the tissue to expose the deep fascia. And then I want to unzip the deep fascia with a Metzenbaum scissors. The muscle that pops out will be the soleus muscle. And then I'm going to use my index finger to create the natural interval or open up the interval between the gastrocnemius and soleus muscle bellies. I like to feel along the soleus side and try to identify the plantaris tendon, which acts as a tether. And once you identify it, I'll pull it out and release it with some Metzenbaum scissors. This has been shown to give you 9 degrees of dorsiflexion by itself, just releasing that. Sometimes it's on the gastroc side and you can't feel it very well. You can get it when you do your gastroc fascial incision. Sometimes it's not there. It's not present about 7% of the time. I would say most of the time I see it on the soleus side, and you can feel it and identify it and pull it out and retract it. Now I'm showing what I used previously, which is a Sims rectal retractor, and you can see how much tension is on the skin. I think this is a big reason that we see wound dehiscence is the tension that's placed on the skin from this retractor, and I'm showing that here. And we're going to take this out and use the Baumann Gastroc Recession system to help open the surgical site and provide illumination intraoperatively. So here's the cannula that's going in between the gastroc and soleus. You want to make sure you're all the way across to the far lateral side. You have plenty of length on the cannula to get all the way across laterally. And now the light source can go in either hole within the cannula. This is a real game changer for me. It really provides significantly better visualization within the fascial layer of the gastroc and soleus. So you can see the light in there and the white, shiny, soft tissue that you can see dorsally and planarly. Dorsally is going to be the soleus fascial layer, and planarly, which isn't a great view right now, but the planar aspect is, or posterior aspect, would be more the gastroc fascial layer. Now I'm going to use an obturator to create a small channel beneath the fascial layer between the gastrocnemius muscle belly and the gastrocnemius fascial layer. And you can either come in from above or within the cannula. And if it's difficult to get this started, you can use a Metzenbaum scissors to create a little channel to get that underneath that fascial layer. And then we're going to slide in what I call the backstop between the gastrocnemius muscle belly and the fascial layer to act as a layer of protection to try to reduce the amount of injury to the muscle. The 2 main complications I see with this procedure are hematoma, calf hematoma, and then wound dehiscence. And this will hopefully significantly help reduce the calf hematoma. And you can see the orientation here of everything with the light and the backstop in place, and then the cannula providing direct visualization. Next, somebody's going to dorsiflex the foot and lift the leg up off the table for you. And we're going to take a long handle 15 blade in from the top opening in the cannula and release the deep fascia from lateral to medial. with against the backstop, protecting the underlying musculature. And that's what I'm doing here. And you can see the angle of my blade. I'm cutting right into that backstop to protect the underlying muscle, but get a complete release all the way from lateral to medial. It's important not to cut the deep fascia. It makes closure of that more difficult. This also helps to protect that as well. And with the light in there, you can readily see if you have a complete release or not. I do like to check. Intraoperatively, I'm trying to get at about 5 degrees, plus 5 degrees dorsiflexion. That's my goal. And you can see here we have a complete release. You can see the underlying muscle belly from the deep fascia. It's important to check intraoperatively. If you're not happy, you can do a second recession in the gastroc fascial layer about 1 centimeter apart. And I just like to rotate the cannula to separate that out, to spread it out a little bit, those 2 incisions in the fascial layer. I would say the majority of the time, just releasing the plantaris and doing 1 recession provides adequate dorsiflexion. Now I like to flush the area or irrigate the area with Marcaine with epinephrine. It helps with hemostasis. It also helps to provide anesthesia, postoperative anesthesia, and we're going to remove the system, turn the light off, and then take out the cannula. I usually put a towel down because a lot of that flush is going to work its way out when you pull out the cannula. It is important to close the deep fascia. I use 3-Vicryl. If you dorsiflex the foot while you're closing the deep fascia, it helps to suck the muscle back in and makes it easier to identify the fascia and also to close it. You have to be careful of the saphenous nerve, which can be right on the fascia on the more anterior portion of the fascia. And if you see any fibrofatty tissue, that's usually where the nerve is. Just kind of push it more dorsally or anteriorly to get it out of the way for closure. And I typically just use some simple interrupted sutures, usually around 2 or 3 here to get this together. If you don't close this, the muscle will herniate out the side of the leg when the patient walks, and it looks odd. So it is important to close this layer. And then for skin closure, I've been using an adhesive suture retention device with 2O nylon, and I'll either use, with those adhesive suture retention devices, you can either use a simple or a vertical mattress. If I'm going to use a running subQ closure with barb suture, I'll do the vertical. If I'm just using horizontal mattress type sutures, I'll use a simple type suture. If this is the only procedure being done, my typical postoperative course is I'll put a dressing around the patient's calf. I usually don't even wrap the foot. I do like to go from just below the knee to the ankle. It helps with swelling that way. It also stays on better. And then I'll let the patient be weight-bearing in a walking boot in a protective fashion. One of the things that patients complain about with this procedure is almost like a Charlie horse type feeling, and that usually gets better after a couple days. But after the first post-op visit at about a week, what I do is I'll just put a Band-Aid over the incision and allow them to take a shower and get it wet, and I'll see them back in 2 weeks and take out the sutures. At 2 weeks, depending on how they're doing, I'll keep them in the walking boot for 3 or so weeks, and then ease them back into an athletic shoe. I ask them to not do any high impact type activity until they get to about the 8-week mark. If a patient does get a hematoma, just use local wound care. Or if the patient does have a wound dehiscence, you can just use local wound care. With a hematoma, it acts very similar to a DVT, even though it's not a DVT, it'll behave similar to that. The calf gets very swollen, a lot of bruising, significantly more pain than otherwise. And really, you just have to kind of ride that out until the body resolves it. But ice helps quite a bit. Sometimes if they're complaining of a lot of cramps or muscle type spasms from the procedure, which is pretty rare, but I would say when I have a hematoma, it is where I would see it more commonly. I'll use a muscle relaxer that actually seems to help more than pain medicine does. And then from here, you can just go to your closure per your choice. And if you have any questions, please do not hesitate to contact me at padehere@gmail.com or check us out at gastroc.com. Thank you.